Dr. Gilbert.
Great. Well, thanks for having me back. I think this is our third session. So we've moved through cystectomy and perioperative chemotherapy. So we're going to dial even further back to earlier stage disease and talk about a clinical problem that if you're taking care of bladder cancer patients, you probably see fairly commonly. And so that's BCG recurrent and or unresponsive non-muscle invasive bladder cancer. So no disclosures related to the topic. So the first thing to kind of level set is different risk categories that have been recognized and codified by national and international, national US and international guideline panels. And so, we think of non-muscle invasive bladder cancer in three categories: low risk, intermediate risk, and high risk. And you can see the different breakdowns of how patients, according to the AUA guidelines or the EAU guidelines, fit into those different risk categories. But low risk tumors would be any TA tumors that are low grade. CIS cannot be present. Tumors have to be small. If you have a recurrent low grade tumor or a large low grade tumor, that would bump a patient into an intermediate risk. An intermediate risk would also contain low-grade tumors invasive into T1 at diagnosis or at recurrence, or any high-grade tumors that are relatively small, less than 3 centimeters. And then high-risk tumors, and this is where we're going to focus the remainder of the talk on, are those high-grade tumors invasive into lamina propria or large TA tumors, variant histology tumors, any recurrent tumors that have not responded to BCG, and carcinoma in situ. And so, as we all know, BCG is the mainstay for these high-risk patients and some low-risk patients. And the way it works is BCG is an attenuated microbacterium used across the world as a tuberculosis vaccine, but also for the management of non-muscle invasive bladder cancer. And for bladder cancer adjuvant risk reduction, it directly stimulates the cell-mediated immune response and upregulates cytokines such as TNF-alpha, INF, gamma, IL-2, IL-12, and IL-18. And this results in a Th1 response in the immune system. And that in turn results in cytotoxicity and stabilization of the urothelium and a risk reduction of recurrence, a significant risk reduction of recurrence, and also a slight, not as pronounced risk reduction in disease progression. So the initial response on first induction is about 70%. And then because of the nature of non-muscle invasive bladder cancer and the unstable urothelium, if maintenance therapy is not used, you'll find that 40 to 50% of those patients who responded initially will recur within 4 to 5 years. There is a latent effect. So if you administer BCG and then look in the bladder too soon and do biopsies too soon, you may falsely categorize that patient as BCG recurrent. So any kind of surveillance biopsies or endoscopic evaluations of the bladder should be put off by 3 to 6 months, particularly on the biopsy side. And we see this frequently. You likely see it in your surveillance practice. If you scope someone too quickly after their induction intravesical BCG treatment, the bladder can look red, and it's hard to discern whether that's BCG cystitis and treatment effect or residual carcinoma in situ. But even if there is carcinoma in situ in the bladder in the early phase after completing intravesical induction treatments, the immune system may still be working. And if you look back a few months later, the bladder may clear. There is some evidence that BCG induction therapy may reduce the risk of progression, as I mentioned earlier, and this comes from EORTC GU-CG meta-analysis of almost 5,000 patients that reported about a 10% progression rate in patients treated with BCG versus a 14% progression rate in patients who did not receive BCG. In patients who have received BCG, but they don't respond to it, about almost a third will progress to more advanced stages of disease, either node positive or muscle invasive, or more frank metastatic disease by 5 years. So when people have a recurrence after BCG, a question is, what is the rationale for doing a second induction, which is common in the guidelines, particularly if the patient has not received any recent BCG within the last 12 months. And the response rates are based on these studies, and you can see about anywhere from 30 to 40, in one study, 50% of patients will have an additional response or a second response to a second induction. Overall, if you pull these statistics, it's over a third of patients will have a response to a second induction. So that is part of our treatment option, and oftentimes the next treatment recommendation for patients who've received the first induction and then go on to have a recurrence. But complicating the situation, and this may be true in Ethiopia and other parts of the world as well, but in the US, in particular, there have been drug shortages for BCG. It's actually been across the oncology and in other drug supply chains. But there's been about 4 or 5 shortages of BCG over the past 4 or 5 years due to the fact that in the United States, only Tice BCG strain is FDA approved. So other parts of the world have access to Tokyo strains and Paris strains, alternate strains that we don't use in our practice. So this has resulted in a real disruption in treating these patients here on our side of the pond. And there's also evidence that the Tice strain may not be as good as the Conant strain, which was the predominant strain used. It was manufactured in Canada. The plant had I can't recall if it was a flooding or fire event, or they had an interruption in their production facility, and ultimately the company pulled out and didn't go back online. So the Conant strain is no longer available for us. But there was a randomized control trial shown here showing that the recurrence-free survival rates associated with the Conant strain are actually better than with the Tice strain. So it's not only do we have an issue with BCG availability, but we may also not be accessing the most effective BCG strains. There is a randomized control trial run by Southwest Oncology Group that's wrapping up now, called SWOG 1610 or 1602 rather, and that is comparing Tokyo strain to the Tice strain, with a third arm of patients getting a prime, a dermal prime with the Tokyo strain. So we'll await those results to see if the Tokyo strain is better and maybe become available for us in the US. I'd be interested in, at the end of the talk, to hear what strains are available for your practices. So there are different reasons that people don't respond to BCG, and so there is some back of the envelope kind of risk calculation when you're counseling patients on their response rate or their likely response rate prior to starting BCG. And this may actually impact, in the setting of supply chain disruptions and drug shortages, this may actually impact who you decide to administer it to versus an alternative therapeutic regimen. And so patients who are immunosuppressed, there's some evidence that as patients age over 80, their immune system doesn't work as well if they're on high doses of steroids or any kind of immunosuppression related to transplantation. They would, or immune-mediated arthritis, for example, or GI condition. They may not be a good candidate for BCG. There's naturally inborn allergy to BCG in some patients. There's incomplete dose and suboptimal administration that can be related to how it's administered or whether the patient can hold the medicine for the full time. It's the most common reason. There can be a polarized Th2 versus Th1 response. that's been reported with higher doses of BCG, and this may underlie why a third or a half cut dose of BCG is just as effective as the full dose, which is one of our strategies for managing BCG shortage periods, is to dose reduce what we're actually giving to each individual patient. And then tumor-induced immune suppression based on PD-L1 and PD-1 and PD-L1. There's also intrinsic tumor resistance that can occur depending on the microenvironment of the tumor. So these are some of the older definitions of BCG recurrence, so BCG failure. And this slide is just to kind of show you that is a little bit of a complex set of definitions that sometimes overlap. It's not very easy to clinically implement, and this is one of the reasons people started moving towards this concept of BCG unresponsive disease, which we'll get to. So to make that complexity simpler, the new classification comes down to really 4 categories of patients. There's patients who are refractory, who have high-grade disease at 6 months despite adequate BCG treatments, or any grade or stage progression by 3 months after their first cycle of BCG. Adequate BCG would be defined as at least 5 of 6 treatments of the induction course and 2 of 3 of the first maintenance, or starting a second induction. So beginning on your second 6-week course and then having disease recurrence. Recurrent disease is any high-grade recurrence after achieving a disease-free state at 6 months after adequate BCG. And that group may, because they haven't progressed by grade or stage, they may be candidates to have that second induction. Intolerant is a patient unable to either receive it or unable to tolerate the administrations. And then unresponsive is going to be the patient population that we're going to really talk about for the rest of the talk, and that is BCG refractory or relapsing disease within 6 months of the last BCG exposure. So this typically is a heavily treated patient population. They've usually received at minimum an induction of BCG plus 1 maintenance or 2 inductions. Sometimes they've received 2 inductions plus over a year or 2 of maintenances, and then they have a recurrence. And if they fall into that category, there's really no reason to give additional BCG because they've received so much of it. We have low confidence, and the statistical probability that they would have a durable or meaningful response to a third induction or a repeat induction after 2 years of maintenance treatment is extremely, extremely low. So that definition has been validated. A lot of work done both by the University of Iowa group and the MD Anderson group on this. And so one of the concepts for BCG unresponsiveness is, when do you recur and how much BCG have you received, how recently? So if you've only received 1 induction course of BCG and it was greater than a year ago, it's worth trying BCG again because you have a high probability of responding in this top curve. If it's been less than a year and you've only received 1 induction course of BCG, it's not unreasonable to try a second induction, but you can see your probability, your response probability is much lower. And then this is really the unresponsive patient group, this lower curve, where less than 20% are going to respond to a third course of BCG with durable response. And that is if you've had 2 inductions or more of BCG, and it's less than within a year, right? Then giving additional BCG treatments is just not a high probability play. So this is one of my mentors, Jim McKiernan, who is at Columbia University where I trained, used to say the most effective chemical treatment or chemo treatment for BCG refractory or unresponsive disease is formalin. So taking the bladder out and pickling the bladder in a pathology jar. But not all patients want that. So, there are second lines and salvage rescue therapy options that we have been using more and more in recent years, particularly since some of these patients will come in advanced age or significant comorbidities. And in addition to having a personal preference against having their bladder out, they just are not great surgical candidates or have significant concerns. And you may have concerns as a surgeon to proceed with a very extensive surgery. And then even among the younger patients, there's, I think, a mental kind of reckoning that they have to go through to accept the fact that their disease is not salvageable with medical therapy before they agree to cystectomy. So it's not infrequent in my clinic where someone comes in with BCG unresponsive disease and they're not ready for surgery and they want to try something. And so these are the different kind of somethings that we can try. And they're a combination of conventional chemotherapies given as intravesical therapies as either single agent or dual agent, or as known as sequence therapy. There was some data, and it was much more in vogue in the 90s and early 2000s to give combined immunotherapy with BCG plus interferon. And then the most common strategies that we're using now, other than clinical trials with novel agents, which we'll touch upon at the very end, are combination sequence treatments. Starting the first one to be used was gemcitabine and mitomycin, but that switched over to gemcitabine and docetaxel, and I'll show you some data on that as well. So the outcomes associated with conventional agents, like a third cycle of BCG or interferon after BCG has been administered, or single agent mitomycin or valrubicin. And you can see that some of these are CIS only and some of them are mixed, and they're all small patient groups, but you can see that the response rates are low. So 20% again for third cycle of BCG, 12% for interferon, about 20% for mitomycin, and only 8% for valrubicin, which is a very expensive drug in the US and is FDA approved for CIS recurrence after BCG treatments. These are all numbers that don't excite me, and I always kind of think back to how much it would cost the patient as well and how much time we're also wasting. So these are the response rates you can expect if you use a single agent conventional treatment strategy as a second or third line after BCG hasn't worked, and they're low enough that I think that you can just pass on them and move on to something more modern. And if you pull all the data for gemcitabine, intravesical single agent Taxol therapy, BCG plus interferon, thermotherapy, photodynamic therapy, and there's one study down here listing mitomycin plus gemcitabine. You can see that most of the report outs of these small, relatively small studies are low follow-up, not very long follow-up. And you can also see that within that not very long follow-up, the response rates are, although variable, and some of them are fairly favorable, like 50% and 40% and 44%. Many of them are about 30%. So a marginal tick up from what we saw with the conventional agents. But again, large signal that there's a lot of room to improve and work on newer strategies for these patients. So what about BCG interferon? This is a little bit historical, published back in 2006. When I was training, BCG and interferon was a very common combination therapy used either in primary setting or for BCG failure. And so this was 1,100 patients of BCG naive and failure patients. This study incidentally was run by and supported by the sponsor who was providing the interferon. So there were some concerns about how the data might have been collected. and potential results favoring the intervention arm. But the induction was a third dose of BCG and 50 million units of interferon alpha 2B with maintenance, and 50% of patients, 50% of the patients on the study required a reinduction. And there was a mixed group of patients. So 13% of patients at the beginning of the study were BCG refractory. So a lot of these, were not adequately, quote unquote, treated with BCG prior. And even though it was a more favorable mixed population, not truly BCG unresponsive, they still had very high failure rates, like 34% at 6 months. And then they had 28% of patients who failed, an additional 28% of patients who failed between 6 and 12 months. And then another 15% of patients failed between a year and 2, and 10% of patients fail after 2 years. So we don't use a lot of this interferon therapy any longer. It is also an expensive adjunct to BCG. So I think relatively low value in terms of what kind of response rates you're seeing. And also the data supporting it is imperfect in terms of how the study was done and the data was reported, particularly in regards to the fact that the patient population was not high risk. It was a mixture of BCG naive, BCG recurrent, and BCG unresponsive patients. So what about valrubicin? So I alluded to this earlier, with a very low risk. This is also a very expensive drug in the US with very low response rates. This was the 2 studies were reported out on this, first by Colin Denny in 2013, which enrolled 80 patients with CIS alone or in combination with TAT1. And they were treated with 6 to 9 weeks of 800 milligrams of intravesical valrubicin. About 40% of patients had received 2 prior BCG courses, so it could be considered BCG unresponsive according to the new definition. And only 24 out of 80 were disease-free at 3 months, which is a common threshold outcome target for these types of trials. And that's another caveat I think that's worth noting, is most of the studies and these percentages that you're looking at are less than 1 year response rates and recurrence-free rates. So just whenever you're evaluating medicines in this space, I think it's really important to understand what their target endpoint was at what time frame. You'll see that most of them are 3 and 6 month report outs, and the story is kind of consistent. What you see at 3 and 6 months is not what you see at 2 years. There's further attenuation and as additional recurrences mount beyond a year. And so they could calculate that 14 out of 80 patients were defined as a complete response. They were disease-free both at 3 and 6 months. So at 6 months, a disease-free probability of about 22%, and at 12 months, 10%, and by 2 years, it was only 4%. So even when valrubicin was kind of replacing interferon in the community, when patients came in to me with either a treatment plan saying that they've been recommended to receive valrubicin, or they had received it, I never kind of took this into my practice, and I would tell the patients who were coming in for second opinion and telling me that their doctor had set them up for valrubicin, I would tell them that's not the right way to go. We should think of something else. So there was an open label second study, a non-comparative study of 90 patients, and they received a more standard 6-week induction of intravesical valrubicin, and 21% of those patients were deemed complete responders with no recurrences at 3 or 6 months. Okay, so what about single agent gemcitabine? So gemcitabine versus mitomycin seems to be have a better disease control rate, and actually is better tolerated because, and you may have seen this in your practice, the mitomycin can cause acute symptoms of urgency and frequency, and then there's this issue of non-healing scars at the TUR site, which is why we've also replaced mitomycin for our immediate post-TUR intravesical administrations in the recovery room to gemcitabine. Because those ulcers, if they occur, they're non-healing and they turn into calcified dystrophic lesions that need resection or partial cystectomy in some rare cases. So mitomycin, I think, has a limited role because gemcitabine is better tolerated and appears to work better. And then in terms of a phase 2 randomized control trial looking at gemcitabine versus BCG, 80 patients with recurrent disease, not BCG unresponsive, but recurrent after one course of BCG, they had better disease control rate than patients treated with a second course of BCG. So that's kind of the rationale for why to use gemcitabine. There was a phase 2 SWOG study of 58 patients who had intermediate or high risk and had failed 2 prior BCG installations. So this kind of approximates the BCG unresponsive category, although the patients were accrued between 2007 and 2009 precedent to that definition. And they received induction 2 grams gemcitabine for once a week for 6 weeks. And then they received 10 additional monthly maintenance treatments, which is monthly maintenance is for chemotherapy is basically now standard part of all of our post BCG or second line intravesical treatment approaches. So it was well tolerated. 96% of patients were able to receive it. The response rate at 3 months was 40%, so double what we saw earlier in the slide set. Median recurrence-free survival was 6.1 months. At 24 months, disease-free survival was about 21%. So that's, again, double of the single digits that you saw with the earlier agents, the more conventional agents. About a third of patients had disease progression and required cystectomy. The toxicity is mainly dysuria and frequency. There were only 2 patients with grade 3 toxicity. One thing about this regimen, I think I have a slide on it later, is it's a little bit, the gemcitabine is acidic, so it can be hard for patients to hold for a full 90 or 120 minutes. And so we routinely administer sodium bicarbonate therapy the night before and the morning of to help patients hold this medicine. So single agent docetaxel has also been looked at. And this again was data that started with Jim McKiernan at Columbia with a dose escalation trial and then a extension study, which we'll just review really quickly, 54 patients and treated with both an induction plus a monthly maintenance course of single agent docetaxel, and 1 and 3 year recurrence-free survival rates were 40% and 25%. So in the ballpark of what you saw with single agent gemcitabine. And about 70% of patients still had their bladder at 2 years. So there was some value to giving this agent if the patient's goal was to try to control their disease and avoid a cystectomy. So, we use multi-agent chemotherapy regimens for almost every urologic malignancy that we treat that's metastatic or in the neoadjuvant or adjuvant setting. So Badri Canetti and Mike O'Donnell both kind of asked, why aren't we combining chemotherapy agents when we give intravesical therapy? They started with gemcitabine and mitomycin. And so there was a 3-site non-comparative study using gemcitabine and mitomycin administered, again, 6 weeks in a row for induction plus monthly maintenance. 47 patients had were either BCG failure patients or intolerant patients. There were 10 patients who were BCG naive but immunosuppressed in that group, and about 30% remained recurrence-free beyond 2 years. Complete response rates were 68%, 1 year recurrence-free survival rates were 48%, and 2 year recurrence-free survival rates were 38%. And they didn't see a difference in response to therapy or durability of response when they looked at both BCG naive or BCG failure patients. There were 10 patients that went to cystectomy for recurrent disease. And there were 2 patients who, despite these treatments, and maybe because they were on intravesical treatments and then get a more aggressive treatment plan sooner, died of metastatic disease. So those are known risks for this, especially in this high-risk population, this high-risk population of BCG failure and unresponsive disease patient populations that we'll talk about in a little bit. There's a risk of patients going on to these 2nd and 3rd line regimens where they could develop progressive disease, and on repeat scans, they start showing signs of nodal involvement or distant metastatic disease. Okay, so in terms of tolerance, 10 patients out of the 47 had urgency frequency, dysuria. 3 patients had a rash, which was believed to be related to the mitomycin, and there was actually 1 patient with pericarditis that was thought to be related to the mitomycin exposure as well. So the regimen was switched to docetaxel as the data came out of Columbia on single agent docetaxel, and there was also a mitomycin shortage. So they flipped to gemcitabine and docetaxel at the University of Iowa, which is where Mike O'Donnell practices, and he's kind of championing this regimen. So 45 patients treated with sequential combination therapy between 2009 and 2014 as a salvage, meaning that patients did not want it, they refused cystectomy, or they were not good candidates for cystectomy, and they couldn't get additional BCG therapy. So this was very early days of using 2nd line sequenced intravesical chemotherapy for people who'd failed BCG instead of just taking their bladder out. And 91% of patients had previously been treated with BCG. Gemcitabine is theoretically induced first because of it requires DNA synthesis to be effective, and docetaxel inhibits mitosis by blocking tubulin disassembly. So if you gave the docetaxel first, then you could argue, microbiologically, that the gemcitabine wouldn't be able to do its job because DNA synthesis had been inhibited. And again, to that point I made earlier, alkalinization with 1,300 milligrams of, we've actually upped this, so 1,300 milligrams of sodium bicarbonate every evening prior to and the morning of the installation. So that's roughly 2 tablets of sodium bicarbonate, which is part of the standard protocols. We started noting in our patient population that they would report inability to hold for beyond maybe 20 or 30 minutes, the gemcitabine, which is the first drug, and that kind of sets them up for failure for the 2nd drug. So we added a tablet. So we use 1,800 milligrams of sodium bicarbonate the night of and the morning of, and we've seen anecdotally better tolerance and holding ability in our patients. Okay, so this is just some more of the protocol, and obviously these slides, if you want to do this, you kind of implement it in your practice, you can take this information from these slides, and I'm happy to follow up and kind of talk through our protocols. But all the details are outlined herein. So the initial results, about 10%, 11% of patients unable to hold all of the treatments. In terms of symptoms, 62% had some sort of symptom, and about 15% those symptoms delayed their treatment. Most often it was pretty mild dysuria or urgency frequency. 10%, 11% had hematuria. And in terms of response effectiveness, response rates at 3 months were 66%, which is, again, a higher number than we've seen before, and 54% at 1 year and 34% at 2 years. Remember, this protocol included a monthly maintenance for 2 years. And they did not see any association between the presence or absence of carcinoma in situ, or TA versus T1, or the number of prior BCG treatments or failures. They didn't see that really impacted the response rate or effectiveness of this regimen. So this was repeated at Johns Hopkins in a cohort of patients between 2011 and 2015. Most of these patients were BCG unresponsive or intolerant. And you see at 1 year, the recurrence-free survival rate of having a high-grade recurrence was 56%, and at 2 years, 42%. And that brings up an interesting and I think important side comment, is that if a patient has a low-grade, a true low-grade recurrence after this regimen, that should not deflect you off of your maintenance schedule, or you should not consider those patients failures. You should treat the low-grade tumor as an incidental secondary low-grade recurrence with resection and continue on with your maintenance therapy. High-grade recurrences would be the thing that would prompt you to tally the patient outcome as a failure before moving to a clinical trial or bladder removal. Okay, so updated data from a larger group of patients treated at multiple institutions reports a 1 year recurrence-free survival rate of 65% and a 2 year recurrence-free survival rate of 52%. And for the subpopulation of patients who are BCG unresponsive with carcinoma in situ in their history, about 50% recurrence-free survival rate at 2 years. And these are by far our best numbers compared to single agents or a third course of BCG or combination course of BCG plus interferon. So in my practice, outside of a clinical trial, this is the standard of care for patients coming in who are BCG recurrent or BCG unresponsive if they don't meet criteria for a clinical trial. But there are a lot of agents. Remember, we still have room to improve. So we're talking about 50 to 60% response rates at 1 and 2 years, which is good, but not good enough. So a lot of interest in additional agents. So we'll talk briefly about pembrolizumab, which has not been the champion in this disease space that it has been in others. We'll also talk more specifically about Instillidrin, which is a viral vector, an adenoviral vector therapy that delivers specific high-dose interferon therapy. And then another type of immunotherapy, an oncolytic virus called CG0070, which we have some experience at our center with. So the Instillidrin, this is Colin Denny's work out of MD Anderson, starting years and years ago. And this actually has been FDA approved, and the company that initially developed the drug was bought out by another company. And so there were questions about whether it was going to be available for practice. And I believe now it's in the US, it's coming online with another transfer and contracts to be able to be manufactured and distributed for clinical care. But there were randomized phase 2 and randomized phase 3 trials for this agent. And you can see that there was in this study published in 2020 by Steve Borgen, who's at Mayo Clinic in Minnesota. There was a carcinoma in situ cohort, and then just a non-CIS high-grade Ta/T1 cohort. And so 55 patients versus 35 patients. And at the, there we go. And so complete response rates at 3 months, again, that 3-month end of study kind of marker that the FDA has accepted as an endpoint for evaluability. 53.4% of the CIS patients had a complete response. And in patients who didn't have any CIS, it was much higher. It was almost 73%. And then if you look at the 12-month data, patients who were free of any high-grade recurrence. Again, remember, high-grade is what we care about. We don't put a lot of emphasis on low-grade tumors coming back during this time interval. You had, if a patient had CIS at 12 months, their recurrence rates were much higher than if they didn't. So only 24% of patients were free of a high-grade recurrence in the CIS patient group at 12 months versus 44% of patients if you didn't have any CIS in the in your history, in your past biopsy samples. So pembrolizumab, this is a drug that also is very kind of like similar to the valrubicin study. This is a drug that is has been well studied, has been promoted in a lot of different disease spaces. Works as a checkpoint inhibitor to block the PD-L1, the PD-1 and PD-L ligand 1 interaction, and unmask a cloaked cancer cell so that the immune system can see it. That's how the drug works. At 3 months, 41% response rate, but by 2 years, this rate really drops down to under 20%. And it's a systemic infusion, so systemic therapy, and the side effects, although not very common, the side effects can be very problematic. So skin rashes, thyroiditis, pneumonitis, requiring high dose steroid therapy can occur in 10 to 15% of patients. So this is a different animal in terms of how it's administered, not intravesical therapy, expensive infusion therapy. You'll see this when patients see medical oncologists, if that's how your referral pattern goes. There are some patients who kind of bypass urology when they have these recurrent tumors and are referred to a medical oncologist. The medical oncologists are much more likely to use this because it's systemic therapy and not immunotherapy. And they quote patients as 40%. But again, if you noticed in the earlier slides, the trend is at 3 months, it's not unusual to see these 40 to 60% complete or disease control rates. And then as you continue to look beyond that by 2 years, that's the real proof in the pudding in my mind. And you start seeing these response rates or disease-free recurrence rates really drop into single digits for many of these agents. Okay, so ALT-803 is another study that's been evaluated. It hasn't been reported out in its final study form, but was presented in abstract form at the ASCO GU Cancer Symposium back in 2022. And so this was a multi-institutional study performed in the US, and there was a cohort A and cohort B, and cohort A was characterized by CIS plus or minus Ta/T1 disease. And you can see here at 12 months, so better longer term endpoint data than 3 months, there was a 62% response rate or disease control rate. And at 24 months, it was fairly durable, still better than half of patients had disease-free intervals extending to 24 months or beyond. And for cohort B, which was just papillary Ta disease with no CIS present, the data were similar, surprisingly. So 57%, 48% for 12 and 24-month disease-free survival intervals or probabilities. So we'll see how the final study is reported out. But the interesting thing about this particular agent is the disease control rates, the durable disease control rates are similar both for papillary disease or disease that contains CIS, which is not something we've seen before. We've typically seen the CIS patients be higher risk for recurrence and have lower disease-free survival as we move from year 1 to year 2. And a final agent to talk about in the closing minutes is CG0070. We studied this in combination at Moffitt with pembrolizumab, so a systemic infusion performed in conjunction with the oncolytic virus installation into the bladder as intravesical therapy. This was work done by Roger Lee, who is a talented young urologic oncologist who has a very specific interest in non-muscle invasive BCG unresponsive disease because he came from MD Anderson, so he had worked with Colin Denny and Ashish Kamat. And so that study, I think, is in the process of peer review, but we were seeing north of 50% complete response rates that were fairly durable, at least to 12 months. This is probably going to be the more important and more definitive study. It's a monotherapy phase 3 trial of CG0070 given alone for BCG unresponsive disease. So Important callouts in the study design are that this is a purer population in terms of definition of BCG responsive disease. It's monotherapy given intravesically with a different type of immunotherapy in the form of an oncolytic virus. This is a single-arm, non-randomized study, so there will be additional studies that are performed in a randomized control trial format. And I suspect if I had a voting right, I would, if this study is positive and shows as promising results as we saw with the phase 2 study, I would put this against gemcitabine docetaxel as a standard of care for BCG unresponsive disease and see which one does better. So the primary endpoint is complete response at any time. I kind of alluded to this safety margin, this timeline for when the cat might get out of the bag, and there's data on this. So the median time for progression for T1 grade 3 BCG recurrent tumors is about 24 months. It's rare that progression would occur within 6 months for this patient group. And untreated CIS has an annual progression rate of about 5%, especially if someone is likely higher than that in patients who've received BCG and failed, because their tumors have been their tumors are selected for a more aggressive phenotype or genotype. In terms of timing of cystectomy, there's different surgical series that have looked at timing of bladder removal for non-muscle invasive bladder cancer and what pathologic and survival outcomes look like after cystectomy. So at Memorial Sloan Kettering, almost 100 patients were treated for either recurrences or disease progression while on BCG. And if surgery was performed within 2 years, disease-free survival was 92%. I think that's 5-year disease-free survival. And there was an 18% risk of progression to metastatic disease. If surgery was delayed beyond 2 years, then there was a significant reduction in disease-free survival and much higher risk of progression to metastatic disease. And there's also some understaging that needs to be acknowledged. So in all of these studies that are looking at second and third line therapies as salvage for BCG failures, there's a small number of patients who move on to cystectomy. And if you look at their pathology outcomes, not all of them are still non-invasive, right? So in the Valrubicin study, cystectomy was performed in over half of the patients at a median of 2 years. 80% were between either no disease in the bladder or muscle invasive. I need to break that out to show how many patients were muscle invasive, but 2 patients had positive lymph nodes. In the Gilbert study, about 20% of patients, 10 of 52, underwent cystectomy and 2 died of metastatic disease that at some point escaped the bladder and was not evaluable or recognizable on pre-cystectomy CT scans. In the Gemdosi study, similar number, 10 out of 45 patients underwent cystectomy at a median of about half a year. And here's a breakdown in terms of pathologic response. 3 patients had 0 tumor identified. 5 patients had carcinoma in situ, 1 patient T1, and 1 patient T4 disease. And you can also see in SWOG 0335, 15 patients who underwent cystectomy. 12 of those 15 had less than T2 disease, but there were a small percentage of patients with muscle invasive tumors. So, if you talk to the folks who give the national talks at the AUA, so I'm thinking of Mike Cookson and Sam Chang, for example, they'll tell you that if a patient is on these second line therapies or kind of deferring or declining cystectomy, they need to be aware that there's like a year and a half or 2 that they can use that strategy before their risk of bad outcomes starts to tick up. And that's what I tell patients in my clinic as well. So this is just a summary of current salvage options. that I think captures how a lot of us are practicing now in terms of the high volume bladder cancer folks in the US. And so obviously patient preferences and their medical conditions and ability to undergo a surgery play into decisions. But you have options. If someone has failed BCG or they're BCG responsive, you have options to try a clinical trial or try an alternative immunotherapy, or you can move them to a gemdosi sequence second line. I think Gemito is no longer really used because, as I said earlier, gemcitabine has basically replaced mitomycin, and then valrubicin, very low response rates. I think its utilization in the US is pretty low. I'm not sure if you guys use it. You can tell me in the comment section. And then obviously clinical trials. So most of the clinical trials available now, at least in the US, are really heavily focused on CIS, BCG unresponsive patient populations. So we see the gemdosi being used more frequently at centers that have the clinical trials open, more frequently for the patients with TA and T1 disease. And if we have a clinical trial available for the CIS patients, then we move them to the clinical trial. The one that we're emphasizing right now is the CG0070 trial, and we also had the ALT-803 trial open before it closed. But there are patients who cannot get on the clinical trial, or the sponsor of the study doesn't have an open slot, and those patients are fine to treat with gemdosi in my practice. They all have to hear about cystectomy at the time of their recurrences, and as they're kind of coming into this this diagnostic entity of BCG disease, even if they are not ready to have their bladder out. And that does make it easier that if they fail gemdosi or if they fail in the clinical trial, it makes the conversation talking about bladder removal a little bit easier for them to process and accept. Okay, so some take homes, really important patient selection for this group. Immunotherapy with BCG reinduction is reasonable for late relapses, so prior BCG exposure greater than a year. Single agent gemcitabine and docetaxel or mitomycin, I think, are reasonable for low and moderate risk BCG failures, but not high risk cases. In high risk cases, I either use sequential gemcitabine docetaxel or consider them for a clinical trial. And I'll absolutely start talking to them about cystectomy, even if that's going to be something that is done a year or two down the road. I think that's it. So it's top of the hour, and I have a few minutes to stay on if there are questions.
Maybe I have a question. Ashley, until Ashley is responding. So thank you for the excellent presentation. It's really a nice one, but we are not practicing this BCG and this the medication because medications are expensive and not available in our setup. But we are still trying to use doxorubicin as immediate intravesical chemotherapy, and also sometimes we use it for other case. How do you recommend this type of usage for doxorubicin compared to the gemcitabine and mitomycin?
So
I do have also the second question.
Yeah.
For the floor closed, I think there is also a clinical trial on bladder transplant in US. I think in US, University of Southern California. So how was it going on? Is that positive? Are you involved on that? Thank you very much.
So first question, post-TURBT, immediate post-TURBT intravesical chemotherapy in my practice is restricted to patients who we think have a low-grade disease or an intermediate risk tumor. And I use gemcitabine. I don't have any experience with docetaxel. I don't think many people are using, so most people who do a lot of bladder cancer work at the cancer centers and at academic centers have made the switch away from mitomycin because of the ulcer itch, problem with it. Those bladder ulcers are just, they're painful for patients and they cause a lot of diagnostic issues, and you're scoping patients afterwards and you're looking at this big ulcer, and it's a setup for urinary tract infections in addition to urinary symptoms. So I've abandoned mitomycin basically in my practice. I don't have any experience with the taxanes as post-TUR treatment. Gemcitabine is a pretty inexpensive drug. It may be less expensive than docetaxel. So that may be something for you guys to look at in terms of a cost perspective. And that would also be, if it is inexpensive and accessible for you, that would also be a consideration to use as an adjuvant therapy for high risk non-muscle invasive bladder cancer. In terms of the bladder transplants story, it got a lot of media attention. It hasn't happened. I don't believe it's happened yet. It was announced at USC by Dr. Menon and a younger surgeon. And they're going to do it in a non-cancer case, obviously, because you're going to have to put patients on immunosuppressive medicines afterwards. So, it's an N of one proof of principle idea that caught a lot of people's attention and imagination when there was a press release about it, but we don't have any data in terms of when they're going to do it. They're in planning phases. So I don't know if they're an animal phase model or cadaveric model. I think what they're planning on doing is probably taking the internal iliac veins and the organ itself and the urethra and doing vascular anastomoses and a urethral anastomoses and urethral reimplantation. That's my best guess. It'll be interesting to see, but this will be something that takes years and years to sort out, to figure out whether a patient like that has an acceptable functional bladder that avoid and is able to avoid rejection on. And then my question is, quality of life outcomes after neobladders are not perfect, but I can imagine all kinds of issues with a transplanted bladder and high dose immunosuppression that probably supersede some of the issues that neobladder patients face. So it may be that the transplant is suitable for a very small group of patients. I think it will be hard for it to beat a neobladder.
Thank you very much. The others, my colleagues may have questions and they can take part in this session. Maybe Dr. Taklabrahn is a senior urologist and transplant surgeon. He was also our teacher during our residency. He's also here if he has some comment to say on bladder. He's also more interested on bladder tumor. So if he has any question, he can, or comment, he can participate on the talk also. Dr. Taklabrahn.
So also happy to follow up. There aren't any questions popping up. I appreciate the comment. So if there are no additional questions, if folks want to share questions or comments via email, I'm sure Ashley can forward them to me or we can reconnect. But I do have a meeting that's coming up and I have to pop off.
Thank you very much.
Thank you so much.
Everybody also. Oh, Ashley is back, yes.
Oh, no, go ahead. I just wanted to thank Dr. Gilbert for his time and you, Dr. Solomon, for helping coordinate. I can also connect you two by email. And then Dr. The other one by email as well.
Okay. Thank you very much.
All right. Thanks, everyone.
Bye. Thank you.
Good evening. Bye.